Consider the clinical reality of slow-growing brain tumors. Over months or years, these masses displace massive volumes of language anatomy within the skull. Despite severe structural distortion pushing brain regions out of their normal physical positions, a patient's speech and cognitive functions often remain preserved. Contrast this slow structural accommodation with the sudden microscopic violence of a focal stroke. A focal infarct of only a few millimeters can cause immediate devastation to a patient's ability to communicate. Why do massive structural displacements preserve human function, while minor tissue losses completely shatter it? Mapping the underlying transmission networks provides a clearer picture of functional impairment than measuring simple lesion volume alone. For over a century, standard neuroscience relied on a rigid, binary map of the brain, dividing language into isolated cortical centers. Under this classical assumption, Broca's area handled speech production, and Wernicke's area handled speech comprehension. Applying this localized paradigm to real patients consistently fails. It cannot account for individuals who present with mixed symptoms, partial syndromes, or atypical aphasias that contradict the textbook lesion locations. This diagram outlines the difference in architectural thinking. On the left is the classical model, with isolated silos. On the right, the modern network model maps speech production as a distributed frontal-insular-premotor network. Comprehension relies on deep temporal-parietal-frontal circuits working in continuous tandem. The defining pathology rule of this architecture is transmission. Injury to the white matter tracts physically connecting these nodes causes as much impairment as severe node injury. Moving to a network model is the prerequisite for accurately diagnosing neurological deficits and preserving patient function in the surgical theater. To dismantle the concept of a single speech area, we must look at how speech initiation travels across a highly coordinated frontal assembly line. The process begins at node 1, the supplementary motor area, the initial spark for speech. The signal travels down the frontal aslant tract to node 2, the premotor cortex, which compiles physical motor programming. Finally, it reaches the insula, crucial for articulatory coordination. The signal finally reaches the inferior frontal language areas, hitting the final output pathways to generate sound. Speech is a progressive assembly line. Localized damage to any specific transmission point along this route yields a completely distinct clinical apraxia. The final output depends on the entire chain remaining unbroken. This clinical profile illustrates how network theory solves diagnostic anomalies in a real patient. Here, we evaluate a 62-year-old right-handed man suffering from a left temporoparietal infarct. His clinical exam reveals a direct contradiction. He speaks with fluent speech, and he comprehends simple commands perfectly. Despite intact comprehension and fluency, he presents with a highly specific deficit. He cannot accurately repeat phrases back to the examiner, making frequent phonemic errors. This specific profile is known as conduction aphasia, and it is the classic manifestation of a network disconnection. In this structural map, the temporal nodes process incoming speech perfectly, and the frontal nodes can physically articulate. The nodes are flawless. The failure is isolated entirely to the physical transmission pathway between them. The arcuate fasciculus has been severed. The patient knows exactly what to say and understands the speech, but the severed pathway prevents the phonological information from transferring from the comprehension region to the production region. Without the topological lens of white matter disconnection, this patient's deficit is physiologically unexplainable. The cortical centers work, but the network is broken. Recovery after a stroke or tumor resection involves the dynamic reorganization of surviving brain architecture. The immediate adaptation mechanism is perilesional reorganization. Surviving cortical tissue adjacent to the dead zone adapts to take over lost functions. In compromised patients, the brain employs homologous contribution. Separate regions in the contralateral hemisphere are recruited to assist processing. Intensive clinical rehabilitation drives the physical strengthening of newly formed compensatory white matter pathways. However, this plasticity operates within strict anatomical limits. The nervous system can only rewire itself if sufficient baseline network connectivity was preserved during the initial injury. Because recovery relies heavily on preserved connectivity, we cannot rely on generalized anatomical maps. medicine must map the precise topology of the individual patient. This matrix details the technologies mapping the patient-specific network. Functional MRI identifies activation in specific cortical nodes. Diffusion MRI and tractography trace the pathways linking them. During surgery, awake direct electrical stimulation actively tests essential sites to prevent deficits. For patients whose active participation is limited, resting state connectivity provides an assessment of baseline language network health. To preserve human language and cognition, clinical medicine must focus less on the localized territory of the brain and entirely on the dynamic pathways that connect it.